Okay, instructor Yvette here from Atlanta Tech, and we're going to talk a little bit about the trauma assessment. We're going to do a series of videos here, hopefully some short videos, things that'll help you remember things that you're looking at, things that you're studying, things that you can go back and rewatch again in a short period of time to help you get better grades and do better assessments and hopefully become better EMTs, AEMTs, and paramedics. Okay, so we're going to talk about trauma assessment today. Everybody should be getting into their assessment phase of uh, either EMT or AEMT or paramedic, whichever one you're in. And you know that there's a difference, or there's two different skill sheets for trauma assessment versus a medical assessment. So you say, what's the difference? Well, truth be told, the difference isn't the assessment itself, it's just in the timing of what you're doing things. Okay? Um, and that probably doesn't make any sense yet, but we'll talk about it here in a minute. The trauma assessment, of course, is focusing on like gunshot wounds and you know things that trauma causes that can be immediate life threats. Okay, and your medical assessment's the same thing. You're looking for those immediate life threats and stuff, but we're looking at things like diabetic emergencies. We're looking at things like respiratory emergencies, cardiac arrest. Okay, so the way that you do the assessment or the assessment that you're going to complete when you're done, they encompass the same thing, but maybe the order in which you do these things isn't quite the same. Also, when you're learning this, it's easier to memorize it or work out a plan for trauma assessment, work out a plan and execute on the medical emergency side for the medical assessment. And truth be told, when you get out into the field or when you're doing your clinicals and stuff, you may have assessments that encompass a little bit of both. Um, so it's just a matter of knowing the steps and knowing when to use what part of each assessment. Okay, so we're going to get into this. Like I said, this is going to be a quick little video on the trauma assessment. And when we're talking about the trauma assessment, um, first thing we got to think about is practice, practice, practice. I talk about this with just about every skill, um, all the material that we cover. It gets easier with repetition, folks. Um, so, like the screen says here, practice until you can do it in your sleep. Um, and if you're lucky and work for some ambulance companies, you can actually get some naps in there. Okay. Um, in the beginning, use your notes, use the PowerPoints and stuff that we've got you, um, and do it step by step. Okay. And eventually, just kind of like learn to walk after you've broken both legs or something. Uh, you're going to use crutches and stuff to start with, and then you're going to start walking slow, and before you know it, by the end of this class, you'll be up and running and have this stuff down pat. Okay. You can't expect to master a skill just doing it once or twice. Okay. I read somewhere many years ago that muscle memory, in order to do a skill proficiently, in my case, it's like drawing your weapon and firing. It takes somewhere close to 10,000 repetitions before you even get close to getting as good at it as you'd like to be. Okay? And it's not just practicing sloppy practice, putting in the time. It's legitimate, trying to do your best every time, speeding up a little bit as you get better at it, taking the crutches away as you get better at it. So if you have to look at your notes in the beginning, of course, do that. And then after, I don't know, 10 or 12 reps of it, you ought to be able to get through the first 5 without looking at your sheet, right? Then as you move on a little bit further, maybe you can get down through uh, AVPU and general impression and all that stuff. And then eventually you'll get to the point where you just may need to look at your sheet one time because you left one thing out. And then after that, you'll get better, and your body, your mind will know if you've forgotten something. Okay, because it's easy to forget things when you're doing these scenarios and stuff. When you're out in the field, we have things called distracting injuries, and you see an angulated fracture of the tib fib, and you go, "Oh, that looks bad." Well, yeah, it may look bad, but if you're not taking care of this patient's breathing and their circulation and stuff, or stopping the bleed, it doesn't matter if they have a broken bone or not. So, anyway, we got to get good at mastering these skills and doing the best we can for our patients. All right, so I talked about the first 5 minutes ago. Everybody should have gone over this. You should see this whether you're in trauma assessment or medical assessment. So the first 5 is, of course, the scene safe. Scene safety always comes first in testing and in your skills. Okay. Your mechanism injury or nature of illness. We talk about this a little bit different. We think of mechanism of injury in the trauma setting and nature of illness more in the medical setting. Okay. But they're both there. Think about both of them. Number of patients, how many patients do you have? Okay. Um, Additional resources. Do you have too many patients? Do you need to call additional resources? What's going on here? And then last but not least is always body substance isolation. Some of y'all will say PPE. Please don't. Know the difference between PPE and BSI. When we talk about PPE, we're talking about personal protective equipment, and that could be things like turnout gear, your boots, that kind of stuff. BSI is body substance isolation. That's to keep you from getting infected with whatever your patient may have and whatnot. Okay, so the difference between PPE and BSI, please be aware of that. Do we have to do it in that order? Well, yeah, and here's why. When you're going down that list, number one, for testing purposes, just like I've already said, for all your skills and stuff, scene safety is always foremost on our minds. Okay? Because if the scene's not safe, you're not going in there. Okay? If you don't have the MOI, NOI, and sometimes, a lot of times, dispatch will even tell you it's one thing when it's another, but you got to kind of be prepared for that call before you can get there. Okay? How many patients? Because if you've got more patients than you can handle, you need to be calling for those additional resources early. And then if you don't have BSI um, here in the lab, that means you failed that scenario. If you don't have it out in the field, it means something. You may catch something that Ajax may not be able to wash off. So yes, first 5 in those order every time. Okay, just get used to it. Okay, I promise. Isn't that hard? It's not rocket science. Even us police guys and fire guys and stuff can do this. So first 5 all the time. All right. So now we've got the first 5 knocked out. We got to think about, is the patient sick or not sick? Okay. looking at our little PowerPoint here, the young lady on the right, the child, looks sick, holding her head, thermometer in her mouth, got that droopy face. Uh, the guy on the left with the big red nose and stuff, they look sick, right? Guys in the middle, not so much. Okay, so think sick or not sick, and we got to get our general impression. Okay, and it's not just how they look. You can hear things. If you hear somebody breathing from across the room, not normal, right? You can't hear a non-sick person breathing from across the room. Okay, so if you can hear them breathing, that might be an indication of how sick they are. Okay, so then we get into our level of consciousness. We use AVPU at the beginning here. Of course, it stands for alert, verbal, painful stimuli, and unresponsive. Okay, remember before you touch that patient, okay, that we have to consider C-spine. Okay, in a lot of the testing scenarios and that kind of thing, if you touch your patient before you've considered that C-spine, it's failing criteria. Okay. And then the last thing that's in this little block is a transport decision. Make your transport decision early. Okay. You've got their level of consciousness. Okay. And what I tell my students is base this transport decision solely on their level of consciousness. Okay. If they have any type of altered mental status, if they're in that V verbal, but they're, incoherent, that kind of thing. If they only respond to painful stimuli, or if they're unresponsive, let's just make that a load and go right away. Okay? Verbalize everything that you do. Okay? And I'll apologize here on the bottom of this slide. I'm not sure if you can read it real well, but it says load and go versus stay and play. We don't really use stay and play anymore because it doesn't sound real professional. So we use stay and assess, but that's just schematics for helping you remember it, think, stay, and play. But when you verbalize it, stay and assess. Okay. Again, little warning there. Make sure you take C-spine precautions before you touch the patient for non-failing criteria there. Okay. Look for those visible life threats. If you look at the right side there, it's the Boston City bombing. You've got two bystanders trying to stop the bleed there. If you look at the patient, the little cartoon here on the left, you'll see some of the different arteries of the body. Okay, and we can bleed out pretty quick with an artery, right? Because remember, after the aorta, then it moves to the arteries, which are still pretty good sized vessels. Femoral artery, I think you can bleed out. I'm trying to remember the exact time, but it's less than 3 minutes. Okay, so if you don't get that bleeding stop, you're not going to have a patient here shortly. So we're going to check life threats. Okay, injuries or conditions that, if not treated immediately, make it impossible for the patient to sustain life functions. All right, so general impression, we get our AVPU and stuff, and we immediately do that scan for life threats. After life threats, we move into our ABCs. We check and make sure the airway is open and clear, looking for foreign bodies, all that good stuff. Looking in the mouth there. We move into our breathing, rate, rhythm, and quality. Okay, this is our B. Adequate chest rise and fall. Can you hear their breathing? Do they have stridor? Are they wheezing? Are they in the tripod position? Okay, these are things we're looking at when we look at breathing. Then we move on to circulation. And when we talk about circulation, number one, we're talking about a pulse, right? Rate, rhythm, and quality. Okay, but then we're also looking at skin color, condition, and temperature. Okay, and the way that you check that is usually the back of your gloved hand on the patient's abdomen because that's close to the core and stuff. We want to make sure they're not pale, cool, and clammy because that's a sign of what? Shock. Okay? So, ABC, rate, rhythm, and quality for circulation. Uh, in a conscious patient, we check the radial pulses. In an unconscious patient, we check that carotid pulse. We check that carotid pulse on the side that's closest to you. Okay, don't reach across the patient just because everybody's got a camera and stuff now, and it looks like you're choking the patient. So don't do that. Carotid pulse on an unconscious patient on the side closest to you. All right, then D, A, B, C, D, deformities, and E, exposed. Okay, so deformities, we're looking at um, exposing that patient and seeing if they have angulated fractures, if they have bruising, whatever else might be going on with them. We got to be able to see that, okay? Especially if they're unresponsive because they're not going to be able to tell you anything, okay? Um, if they're if they stub their toe, they don't necessarily have to get trauma naked, right? Um, if they warrant it, right? If they're unconscious and stuff, yeah, let's get them trauma naked, and we'll show you different ways that you can cut the clothes and stuff where you don't expose them too much, but you're able to see everything that you need to see. Okay, so trauma, definitely expose that patient. In medical emergencies, if they're unconscious and stuff, you may want to be exposing them too. Okay, if you have an anaphylactic patient who was stung by a bee, uh, you're not going to be able to control that anaphylactic allergic reaction until you remove that stinger. And to remove that stinger, you got to find out where it is first. Okay? So think about these things as you're going through your assessment. So A, B, C, D, and E. All right. And then I always tell my partner, hey, give me a set of vital signs. This is where I remember this. It's a good spot. Partner, get me my vital signs. Okay? Start with a pulse ox. Give me a blood pressure, blood glucose. I've already got a pulse. Um, get pulse oximetry on them. Let's figure out what's going on here. Okay? And then after you receive some of those vital signs back, we can start on our treatment. Okay? Um, Everybody's always quick to come on, and you got a patient with difficulty breathing, and you want to throw a mask on them real quick. Okay? That's good. You're trying to help your patient out and stuff, but once you put a mask on them, now what was their true baseline vital? What was their SpO2? Okay? It takes you an extra 5 seconds to get that SpO2 and figure out whether your treatments are working or not. Okay? So there you go. Blood pressure cuff, blood glucometer, there's your pulse ox. All right? Then we're going to start working into our head to toe exam. Okay? Plain and simple. Head to toe exam. Okay? Deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, laceration, and swelling. DCAP BTLS, when you're testing, you have to say it out the first time. After that, the proctor will usually let you just say DCAP BTLS. Okay, but you got to be able to say that. Okay, deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. Over and over. All right, so when we start with the head, DCAP BTLS, right? Deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, laceration, and swelling. We're going to move from the back to the front or posterior to anterior. We're going to check the eyes, make sure they're pearl. We're going to check the ears for CSF, which is cerebral spinal fluid, blood, any fluids. We're going to check the nose, same thing. Check the mouth, blood, vomitus, teeth, anything that could obstruct that airway. Okay? Then we're going to move down to the neck. Okay, when we get to the neck, we're looking for a couple things. First thing is DCAP BTLS. You'll hear people talk about step offs and that kind of thing. That all falls under deformities or punctures, penetrations, all that good stuff. So DCAT BTLS works just fine. Okay, then we're going to look for three additional things. Tracheal deviation. Okay, the trachea, your windpipe that's located in the front portion of your neck here in the front, should be midline. Okay, if it's not, if it's deviated to one side or the other, then we have tracheal deviation. Okay, jugular vein distension is what you're looking at right now. The old guy with the gold necklace here, um, he has a little jugular vein distension. Um, Jugular vein distension, if they're laying down, not so much. That's where the blood pressure is heading that way anyway. But when they're sitting up at over 15 degrees, if they're still getting that, then we have jugular vein distension. The other thing we're going to be looking for there is subcutaneous emphysema. Okay, and this is air leaking up under the skin there. It'll feel like the little packing roller thing, with the bubbles in it that everybody likes to pop. That's what subcutaneous emphysema is. Little air pockets underneath the skin. Okay. After we check the neck, while we're here, let's go ahead and measure and apply a C-collar. Okay, if it's needed. This is a trauma, right? So measure and apply your C-collar before we move on from the neck. Then we move on to the chest. Of course, the chest, DCAT BTLS. We're going to check the shoulders. One of the easiest bones to break in the human body is the clavicle. So we're going to check that clavicle. We're going to check the sides of the chest. We're going to look for flail chest. And the definition there is on your screen. Flail chest occurs when two or more ribs are fractured at two or more places, creating a free movement segment, and that's going to cause that portion of your rib cage to move in the opposite direction of the rest of your chest when you're inhaling, breathing, that kind of thing. Okay, so like when you breathe out, your chest is going to come back in, right? Because you're getting rid of that space. Okay, so that section, the flail chest section, will move out. When you're breathing in, your chest expands. That portion of your chest is actually going to go in. Okay, so that's flail chest. Paradoxical movement is when that is moving. Your chest is not moving or at the same time. So you may have one side of the chest expanding and one side not. Okay, when we're looking for those things, we're looking for things like a pneumothorax, something like that. The lung on one side or the other is not inflating like it should be. Okay, and then of course subcutaneous emphysema again, which is the skin crackles. While we're here, we're going to check breath sounds. We're going to listen with the stethoscope, and we're going to check mid-clavicular on both sides. Then we're going to check on the sides. Okay, so mid-clavicular, mid-clavicular, and then we're going to check mid-axillary and mid-axillary. Okay, and then of course we're going to check heart tones. Okay, then we're going to move down to the abdomen. Of course, the abdomen, we usually divide it into the 4 quadrants. Okay, and this is a good little schematic to help you remember what's in what quadrant. Okay, so we're going to palpate, and we're going to be looking for a few things. All 4 quadrants, and we're going to check for tenderness, rigidity, bruising, and palpating masses. Okay, 4 quadrants. We're going to check for 4 things. Okay. Then we're going to move into the pelvis. We're going to check for stability and crepitus. Crepitus is the sound of like bones scraping together. So we're going to push down and in. If the patient is complaining of pain in the pelvis, please do not push down and in. just assume that there is something wrong with the pelvis and treat it as such. Okay. The thing about the pelvis, it's a big bony area where there's a lot of fluid stored in the pelvis. Um, so if you get an injury, a fracture to the pelvis, you can lose a lot of fluid. So we want to stabilize that and not cause any more injuries. Okay. Also, if they have a broken pelvis, log rolling the patient is no longer an option. Okay. So 2 times when you don't log roll a patient, for sure, suspected pelvic fracture and bilateral femur fractures. Okay. Either of those are occurring, uh, make sure you don't log roll the patient because that is an automatic fail. Pubic region, of course, we're going to do the priapism sweep for males, uh, which could be indicative of A, them taking some type of medication, or B, some kind of brain or cervical spine injury. And of course, in females, we're going to look for fluids and bleeding because their genitalia are mostly internal. Um, so we're just doing a quick look, seeing if we have any bleeding, life threats and stuff out of there. Okay. All right, then we got to move into the lower extremities. Again, DCAP BTLS, and we're checking pulse motor sensory, um, treating things as we find them. Um, and we got to check out those legs. Okay. Then we get to the upper extremities. Again, DCAP BTLS. We're going to check pulse motor sensory, and we're going to check cap refill time. Now, cap refill time in adults is not as a strong indication of shock as it is in pediatrics, um, but we use it all the same. Okay. Um, so check out the upper extremities, and wouldn't you like to be an AEMT or a paramedic starting an IV in those veins? All right, so log rolling backboard. Took me a long time to find this picture. It took me quite a while to find this picture. You'll notice in the picture there that the flight nurse or flight paramedic, whoever that is getting ready to do the log roll, and she takes her arm off the patient's shoulder. Okay, do not take your arm off the patient's shoulder. Okay, failing criteria for any of the old guys for sure, um, and it's just bad practice. The shoulder is where you're keeping your stability on the upper portion of their body, the same as the paramedic or nurse there at the bottom has a hand on the hip. Okay, so we want to stabilize the patient, avoid excess movement, don't take your hand off the shoulder. Okay, we're going to do this on the head person's count. Um, Again, note on the bottom there, if they have unstable pelvis or bilateral femur fractures, we're going to have to use the scoop stretcher or some type of alternate lifting technique without log rolling the patient. Okay. If we are going to log roll the patient and they don't have unstable pelvis or bilateral femur fractures, we're going to log roll them on their least affected side. Okay, so if they have a femur fracture on the left side, we're going to log roll them to the right. Make sense? All right, so we're going to secure the patient to the backboard with at least 3 straps, chest, pelvis, and legs. Okay, then we're going to secure the head to the backboard. Somebody else, how do they remember it? Nipples, navel, knees. If that helps you, always secure the chest to the backboard first. Again, you're providing support to the patient, then the pelvis, then legs, and make sure to secure with blocks to the headboard. Okay. So what else we got to do? All right, we're always going to be reassessing this patient. Okay. Um, Cardinal rule when we talk about EMS testing and national registry testing and stuff, stable patient gets reassessed every 15 minutes, unstable patient gets reassessed every 5 minutes. Truth of the matter is, um, you'll constantly be checking on your patient, okay? Especially if they're an unstable patient, you're just going to be treating, checking, treating, checking, treating, checking, probably the whole way to the hospital, okay? Stable patient, you'll probably be treating a little bit, working on your report a little bit, checking on them, and uh, just listening, checking to them all the time. Okay, we got to make sure our interventions, are they helping the patient? Are they not getting better? Are they getting worse? Okay. Um, is there anything else we can do to help improve this patient's condition? Okay. And then one of the most important things is we're going to call the receiving facility. We're going to make our report and tell them we're on the way. Especially with unstable patients, um, cardiac arrest patients, gunshot patients, that kind of thing. We're going to give that facility a heads up so that they can prepare for us getting there with our patient. Okay. Also on the way, um, you need to obtain your sample history. Every class talked about sample history, signs and symptoms, allergies, medications, past pertinent medical history, last oral intake, and events leading up to. This is a trauma assessment, but we're still going to get a sample history. Okay. Um, Usually I'm getting this, or as soon as we get them loaded into the ambulance, getting some of that history going, figuring out what's going on. Okay, signs, symptoms. Again, this will be available on your blackboard here shortly. And then OPQRST. We usually think about this when we're talking about pain patients. Okay, but it's also good for other things like breathing difficulty, labor and obstetrics patients, that kind of thing. Okay. Onset, provocation, palliation. Remember what makes it better or worse. How does it feel? The quality. Does it radiate? Does it move anywhere? Severity, a scale of 1 to 10. And time. Time different than onset. Okay. This time is more, we're talking about, is this the first instance? Has it happened before? Comparing it to other instances. Okay. Um, Remember, folks, this is your patient's emergency, not yours. Okay. That's probably one of the biggest things that I learned my first years as an EMT is no matter what's going on with that patient and stuff, it's your job to keep calm, keep your cool, keep things going down the right road. Okay. It's maybe the worst day in their life. Okay. Um, but you got to keep your wits about you, and this is part of what the training will help provide. So you may get there and see a really bad accident. Um, Patients really tore up, and you go back to your training and say, I got to do a trauma assessment. Okay, is the scene safe? Uh, and work through your list, okay, that you've been trained to do, that you've done hundreds and hundreds of times just in training, okay, and it'll help you fall back and do the best thing that you can for your patient. Okay. Make sure they all get some oxygen. Okay. Um, Again, this little reminder to maybe hold off your oxygen therapy until you get a baseline SpO2. Um, if you get stuck, think about vomit. Okay. Think about how you're going to vomit if you can't remember how to do this. Okay. Vomit is a little acronym we use uh, just to kind of remember, hey, did I cover all the bases? And what it stands for is vitals, oxygen, monitor or medications, IV for advanced EMTs or interventions, right? And transport. Did I make my transport decision? Okay. Um, don't operate outside of your scope of practice. Always take care of your patient, do no harm. Any questions? All right. I'm sorry this ran a little bit longer. 35 minutes ain't too bad though. Again, it's just reference, and you'll have this material on Blackboard as a PowerPoint, and I'll also try to put on there the list for your trauma assessment and your medical assessment here in the next couple days. All right, appreciate it.